Good morning. This is the Board of County Commissioners Board Work Session. It is Wednesday, May 24th, 2023. It is 10:06 a.m. The session is set to go until 11 a.m. This is a hybrid work session. We're at 3000 Pacific Avenue Southeast, room 110. I've been wanting to say public hearing. I don't know
Just
why
keeps
it's
going.
like. For public virtual attendance, you may follow along on the Thurston County YouTube channel. I'm Carolina Mejia. I'm the chair of the board. Vice Chair Ty Menser is excused for this meeting. And to my left, we have Commissioner Gary Edwards. We have a room full of people today, and we'll go around the table and do introductions. Patrick, we'll start with you.
Well, good morning, everyone. Good morning, Commissioners. Patrick O'Connor, the Director of Thurston County Public Defense, here in support of the LEAD program.
John Tunine, Prosecuting Attorney.
Morning, Commissioners. I'm Joe Avalos. I'm the Chief Operating Officer for the Thurston Mason Behavioral Health Administrative Service Organization.
That's a mouthful.
And the Administrator for Olympic Health Recovery Services. So,
You need two business cards?
One on each side.
One on each side.
Good morning, Jason B. Mortensen, the Substance Use Disorder Administrator for, again, Thurston Mason Behavioral Health Administrative Service Organization and the Thurston County LEAD Program Manager.
Katie Zerzik, I'm the Opioid Response Coordinator at Public Health.
David Bain, I'm the Director for Public Health here in Thurston County.
Rob Gilder, Assistant County Manager.
Ramiro Chavez, County Manager.
Leah.
Good morning, everyone. Leah Landon, Thurston County Criminal Justice Regional Program Manager.
And so we're all here today for a LEAD briefing, and this is an informational session. And so with that, I believe we have a presentation.
Yeah, and just a couple opening statements, Madam Chair, Commissioners. I know the board has been well aware about the LEAD program. The board was involved way before this was implemented, when we were considering getting a grant. It was a pilot program. I believe now the legislature has allowed us to continue with this LEAD program. Our current grant ends at the end of June. And again, I think is the I believe the right time for the board to hear the successes of this program and perhaps how we're going to plan to move forward. That's really a great opportunity for you to learn the details. I know that you're well aware of what the LEAD program is all about, but I think this is an opportunity to get into a little bit of a granular type of information. So David, I think let me see if I can share the screen.
Okay, yeah, and I'll tag team this with Katie Strzik, who's really been in the weeds with this. I'm really grateful for her work on this. So as you guys know, we contract directly with HCA for funding for the LEAD program. Like Ramiro mentioned, the current contract ends in June. We've got about $1.1 million of total funds available. A key thing to note here is that these payments are based on the completion of deliverables versus cost reimbursements. We have two subcontracts, which is why my friends Joe and Jason are here. We've got one for program management and one for direct client services. And these contracts are for reimbursement of actual costs as well. In April, we did an extensive look at the PHSS side of this contract and found a number of issues that I moved to immediately correct. You'll note them on the slides. One of the significant ones was that subcontracts with TMBHO and OHRS had not been awarded beyond 2021. So they operated for a year without a contract with us. Another finding we had was that the contract between HCA and PHSS required use of specific data software, Gelada, and the implementation of that data sharing and upload had actually not started. We also noted that the contract that we had required monthly data reports to be uploaded into the system. And we discovered that no data reports had actually been uploaded or submitted. Another finding for us was that the contract requires us to submit meeting minutes for all of our advisory boards, technical assistance calls, steering committee meetings. We had about 8 months where there was not submissions. We also needed to have monthly progress reports submitted with various pieces of information and data. And there was at least 3 months where there was that report was not submitted.
I don't want to
Go ahead.
mess things up, but why? I guess my question is why? If there are requirements
Yeah,
to keep everything going, why not?
Commissioner,
What's going on?
this is sort of the question. Obviously, as the new director coming in, I had myself. We had a previous staff person who was.
Huh?
We had
I don't, we need to work a fine line on this, and I think that's an excellent question. And I think we discover all the findings when the staff members separated from the county. That's when we start realizing that we had those gaps.
That's all I was gonna say was.
And
the staff
as
member
a
left.
result of that, and David is gonna come back and tell you what we have done to address those issues. So,
Okay, you've got a follow-up of the why.
yes, yeah,
Oh,
so.
well, thank you. I
yeah,
just couldn't
so-
hardly stand it.
But, very good question, and fortunate, that's how we get to the point when, that staff member separated from the county, we realize the magnitude of the issues that we have not able to
Okay.
perform.
I'll be patient.
No, you're good. No, and County Manager, I appreciate
Excellent
that. That is a simple answer to the question. Next. Slide. There we go. So those are the unhappy parts. So we've spent the last 5 weeks spending a lot of energy and time on getting up to speed again. And so Katie, along with our partners, have done a lot of catch-up work. So as of May 2023, we've done the following list of things. All of our missing meeting minutes and the technical assistance notes were submitted to HCA. We did actually finalize the template, the spreadsheet we needed for data sharing. We have now had a contract approved and signed with our partners. Each of the missing progress reports have been submitted to HCA. And then HCA actually authorized back billing for all the outstanding deliverables. So we were able to get paid for those reports, even though they were late.
Yeah, and as a full disclosure, when we started looking at the gaps, in the last few months, there was a financial element. There was an impact to the county. So implementing those strategies and corrections, we're able to justify the back billing, and that's the last bullet on this. So, so I believe we implemented enough remedies that the county was no harm financially, and I think that's a win.
Can I have a little dialogue here, Madam Chair?
I have a lot of thoughts, but I'm.
We had some discussion some time back that we were not getting our billing out from the health department on other things as well. I mean, is that?
Medicaid.
Yeah, Medicaid issue and stuff like that. So has that been rectified as well? Or are we just focusing right now here? And I shouldn't even bring that up until we have another topic.
Yes,
And I'll do
so
that.
the conversation today is specifically to lead. That may be related to the overall issues that you've been aware about the billing. The overall billing is being corrected, I would
Yes.
speak overall in the organization. This is specifically is related to lead, that it was on one staff person.
Our billings to Healthcare Authority for this program have been submitted through March of 2023, and our April billing will go through likely this week, if not early next week.
Thank you.
My question is, right, we've addressed the issues that were happening, but in the corrections, I don't see a checks and balances, right, for this not to happen again. And so my question is, what are the checks and balances? So if this was because of a staff person that there were a lot of very concerning findings. And how do we stop this from happening again? What's the checks and balances? What's the approach for that to fix this from happening again?
Yeah, thank you, Madam Chair, and I appreciate that. Some of the strategies that we have implemented, we're going to bring the administration of the program under the Commissioner's Office, and that will be Leah is going to be administering the program, and it will be obviously with the program management from the contractors here and the help from Public Health and Social Services. We are in the process to signing an MOU between the Commissioner's Office and the department to formalize what that is. But that is the check and balances that you absolutely looking for, and that's what, at least from my point of view, we need to implement. And that is why Leah has started getting involved on this.
The last sort of correction I wanted to note too was with Gelada, which is the data system. Just to note that, we had not previously been using this system and we're moving forward with that. And Katie, actually, if you want to talk a little about this, I can kind of hand that to you real quick.
Yeah, so for Gelada, we're required to use it per our contract with Healthcare Authority, and kind of the simple breakdown of that is through the data system, the ASO would send the actual data reports to Public Health. We would upload them through a secure transfer file process into Gelada, and then we'd be able to pull monthly reports from Gelada for submission to Healthcare Authority. We had not been utilizing the system at all, and so none of the data for the last almost 2 years has been entered into Gelada. So we've been working with Gelada for them to finalize the Thurston County specific interface. We have the template ready for submission, so we'll be able to upload one large data file as soon as our interface is done. So the ASO will send over essentially all of the referral data for the last 2 years. We'll put it into Gelada and be able to pull those monthly reports to be able to submit them to Healthcare Authority to back bill then for all of the months that we've missed our monthly data reports. And then we spoke to Gelada on Friday of last week, and it looks like our interface should be done anytime this week. And so within the next week or two, we'll be able to have all of our data from the last 2 years finally entered and begin regularly using the system.
Katie, I want to thank you because I know that you were tasked with a lot of this. So I know you've been very busy. I know David told me that you were trying to do the minutes and trying to submit those. So I know you've been working really hard, so thank you.
I do want to address too really quickly the idea about how do we prevent this from happening again. And I think us having better integration with the Commissioner's Office will be incredibly helpful. And I think as part of the MOU, kind of the internal MOU between PHSS and the Commissioner's Office, it lays out sort of what roles that public health has when it comes to the data and the fiscal parts of it. So there's clear things that we need to do regularly. And for me, what I've been really grateful for is I'm getting weekly updates from the program about where we are with statuses of things. And so that I have awareness regularly of what's going on. So I don't go months without knowing where we are on pieces of the puzzle. But I think that our partnership with both the ASO and the Commissioner's Office is going to have a much more robust program for us and partnership for us overall. So
that correction has also included transparency with our subcontractors as well. So the same information that's being sent to David on a weekly basis and the reports that are being submitted to Healthcare Authority include both public health leadership as well as our subcontractors. So everyone sees the same information and sees when everything is submitted.
Guess I will thank our subcontractors too for having patience with us as we work through this. Yeah.
So and I know David is going to close on this here shortly, but the good news, and the good news of all this is we're in the position to, see, identify the gaps, mitigating the gaps, and I believe the county and its partners is going to be in a much better position when the new grant comes July 1st. And we're going to be working on refining a little bit of the contract language with our contractors. And I think there's really just I believe the right time to go through this, lessons learned, identify the gaps, mitigate the gaps. And so we'll be in a much better position coming up in the long term.
I wanted to move to our subcontractors. One of the things that I know that the board was interested in learning was, outcomes from the program, deliverables, what had been happening. And I want to turn over to Jason and Joe for this part of the presentation.
Thanks. Thank you. So I thought we'd first start with just explaining a little about who we are as a subcontractors, because we're very closely linked, and it kind of ties into how we were able to continue doing the program in spite of not having a contract. And you mentioned the Gelada issues. That was primarily on Gelada, not on anything public health had to do. They weren't ready. Gelada wasn't ready until I think recently, right, with some of that stuff. So some of that was on their interface. But so we are in this iteration with the Thurston Mason BHASO. We've been in existence in this form since 2016. We are quasi-governmental, so we do have two Thurston County commissioners, Commissioner Edwards and Commissioner Menser, on our board, and our board chair, Commissioner Kevin Schutte from Mason County. So we contract directly with the state for behavioral health crisis services and other non-Medicaid supports for the Thurston and Mason region. We also hold several contracts with Thurston TST to provide clinical and contract oversight for behavioral health programs that have kind of integrated services with our ASO funding. And with the LEAD program, we applied for a competitive RFP and were awarded that in, I believe it was 2018, I remember now. With Thurston County, we did the same thing with Mason County a year earlier. And the most recent, 2 sessions ago, Blake decision also created a pathway for something called Recovery Navigator Program, which was intended to provide a LEAD-like program in all 10 regions in the state for that service delivery. As we already had LEAD grants in place in both Thurston and Mason counties, we submitted the plan to roll that RNP funding directly into the existing LEAD grants under the control of Thurston County and Mason counties respectively. So what we have is essentially an enhanced LEAD project for the last couple of years here. So next slide, or next. So that's our administrative side. In 2018, the same statute that created the BHASOs also allowed for ASOs to have a direct service arm if they so chose to do that. We chose to do that along with King County and Spokane ASOs, and with particular focus on delivering really services that are meant to address folks that are in the gaps. So we don't do traditional outpatient or inpatient services. We have a great network of providers in the region that handle that. Catholic Community Services, Behavioral Health Resources, Northwest, we've got a bunch of those folks that already do that work. So we really focus on crisis services, jail diversion services, and hospital diversion. So where LEAD fits into the jail diversion piece of our work, but it's surrounded by all the other supports that we have at OHRS. So you could have a LEAD participant that might need a crisis service and they have access to that 24/7. Or if they, hope this doesn't happen, but sometimes if they happen to go into jail, they meet with our jail team in there and we connect them all back to the program they're supposed to be in, and then of course referred out to the appropriate services in the community as needed.
So I'll do a little bit of real quick overview of what LEAD is, just to make sure everybody's on the same page. So at its core, LEAD is a long-term intensive case management program with a focus on harm reduction and trauma-informed care. Also adjacent to that is the collective impact aspect of LEAD. The focus is on systems change, bringing diverse stakeholders together to participate in the program for the benefit of those that are referred. With the harm reduction aspect of it, the program is really centered on outreach. We don't have an office-based type model. It's about meeting people where they're at, both physically as well as where they're at in the stages of change. And it's a broad array of services coming from the peer-led model of helping people navigate behavioral health needs, medical needs. The team was just talking about social isolation impacts recently. So all of the kind of basic needs that help somebody grow and progress. And when someone's referred to LEAD, they essentially can be a participant in LEAD forever. Most of our people tend to stabilize and transition out of services around 6 months. But we've had people that have been in the program pretty much since the beginning, and often we have people that will sometimes disengage with the program for a period of time and then re-engage as difficulties re-arise or they see a need for some support. There is also flexible supports available. Funding for that has been really helpful both for engagement and also just on resolving some of the issues that people have. I'm going to get into a little bit more momentarily, but as I mentioned, there's two parts of it. There's the direct case management part of it, helping take care of immediate needs and long-term stabilization. And then there's the collective impact where we have operational work groups that meet on a weekly basis talking about the day-to-day functioning of the program. So that primarily includes law enforcement agencies that are participating, the prosecutor's office, the case management team. We have representation from crisis services, the coordinated entry housing system, and some of the other outreach programs like Familiar Faces and Crew are represented as well. And in those meetings, we talk about what's going on with people that are being referred to the program, any challenges, successes, just how can we make sure all of our partners are engaged in moving things forward. There is also the policy coordinating group. We call ours the CAB, the Community Advisory Board. So that's the list that was also shared out with the materials for this meeting. A very, I think, broad and diverse group of people coming together to support this program, help guide the direction of the policies that are formed to provide the framework for the work that's being done. And that's got, again, law enforcement agencies, public defense, prosecutor's office, lived experiences represented, provider agencies, a lot of broad stakeholders that are at the table contributing to this program's work. So as was already talked about a little bit, and as was already acknowledged that you know, LEAD started out in Seattle a long time ago now, 2017, I think it was, no, 2011. And through this research with that site and other sites, there was huge reductions in recidivism rates that were found. So it's grown broadly. As was already talked about, this county responded to the RFP from the state to get a grant going. And like Joe mentioned, we participated in Mason County's LEAD grant application as well, and then came on about a year later with this project. And similarly seeing a lot of people's complex issues get resolved that are referred to the program. The main goals that were outlined specific to Thurston County LEAD are the increased use of non-emergency community behavioral health services, which we'll see highlighted in the dashboard, increased resiliency, stability, and well-being for program participants, which I can also speak to, reduced reliance on jails for individuals with behavioral health conditions, and reduction in arrest, time spent in custody, and/or recidivism for program participants.
You just mentioned a couple of things and you said, you know, I can speak to these items, and I kind of like to hear that from you and a little bit more, so.
Definitely. That's where we're at, so
perfect.
So program data, I think the original invite for this that went out, there was a lot of the bullet points from the contract around some of the deliverables and measures around what's collected around demographics, contacts with law enforcement, those types of items. So that's what we're gonna get into now. I'll start high level. What we're seeing in the data is a lot of people that we're seeing referred to the program are unhoused, a lot of comorbid mental health, physical health conditions, a lot of complex needs. Most people referred to the program have outstanding legal issues that need help being resolved, as well as whatever current contacts they're having. So a lot of complex needs that we're helping address. And so part of that is, you know, like was mentioned, reducing their contacts with law enforcement, but also addressing their immediate medical needs, helping them navigate the housing system, whether that's doing, the team has been trained to do the applications for the coordinated entry system. So helping walk them through that. A lot of, you know, wraparound intensive case management to address all their unmet needs to increase stability. Some other data points that are going to come up here is around the referral sources. So originally when the grant was applied for, possession charges were seen as an easy go-to for referral to the program. Right after that, the Blake decision happened. So there's a huge change in how things were being addressed. And some other legislation came through around law enforcement that impacted some of their contacts. So we're not seeing as many referrals from law enforcement to date as we would have originally thought. Still have some, and we're still definitely serving the intended population. Everyone we have in the program has a history of contact with law enforcement. And like I mentioned, many of them have outstanding legal issues that we're helping them resolve. And then also through the data, we can see that in general, the racial ethnic demographics are similar and comparable to what we see represented in the jail population that's served.
So just can I ask a quick question where you just said that there's not many touch points from like law enforcement, right? And why is that? Like, is it because of, training? Is it because they, what is it specifically that is providing that gap?
Primarily, it's legislative changes in the Blake decision. We have, most of the bigger law enforcement agencies participate in our weekly meetings, are there, they're very engaged, they support the program, they help us track down people when we can't find them. We get a lot of referrals through the co-responder programs that work with some of our local law enforcement agencies. So that's, at this point, that's Olympia, Lacey, and the Sheriff's Office that have co-responder programs that refer quite a bit. But the big changes were Blake decision making personal possession no longer a crime. The way the law changed with 5476 with the mandated 2 or 3 referrals before a charge could be filed. Most law enforcement agencies, there was no effective way to track that. So across jurisdictions, that didn't work functionally. There was also some laws that came through around probable cause, use of force, and then personal liability for officers. So there was
We saw an overall reduction in law enforcement response to behavioral health with House Bill 1310. That happened 2 sessions ago as well.
Yeah.
So that was a big piece of it.
Yeah, there's a big impact to referral to crisis services too.
I already knew that, okay? So I'm just gonna suggest that you guys don't be so damn hesitant about saying why. If you want this program to succeed, tell the truth, the whole truth, and nothing but the truth, that the legislature screwed this mess up. And don't hold back, because we're never gonna get anywhere if we dance around these issues. So anyway,
there's
it's
anything
frustrating as hell to me. I'm gonna be as blunt as I can be.
Can I add another thing on top of it? I agree with everything that's been said in terms of the impact that Blake had and the law enforcement restrictions and so forth. Law enforcement, I agree, I think is very hesitant to do contacts now with folks, well, up until the 5536, and we'll see what happens there, but they basically gave up on doing drug enforcement, drug possession enforcement, right? And then also a lot of other more minor offenses that would be the kind of thing that you would divert an arrest to lead from. So, and the other thing that contributed to this, frankly, was pandemic, because law enforcement stopped doing any arresting or booking for anything that was basically nonviolent. And so an officer on the street is not gonna do an arrest diversion when there's no arrest, right? Because they can't book. And so I think what you had is you had a number of different things that were happening all at the same time.
A perfect storm, so to speak.
Yeah, now, the law enforcement referrals that did happen were social referrals. Those were pretty good, I think, when it started. And then we saw a dwindling of that. Was that kind of in correlation with 1310? Because I think they stopped even having more, the social contact started to reduce because of that as well. So it's, there's been a number of different contributing factors to that.
And we have seen an increase in those social contact referrals with the co-responder programs.
Right, and that's been our method to try and address that. Is we first partnered with Lacey Police Department for a mobile outreach team, their MOT team, where we embedded crisis clinicians and certified peers 7 days a week, 10 hours a day, and they are dispatched. They respond to behavioral health calls. Most of the time, actually, without law enforcement, they go directly. And in the times that they do need them, law enforcement will assist. So we started that with Lacey. We partnered with Olympia Police Department for designated crisis responder. And now we've got the scout team with the Sheriff's Department that started just this year. So that has been a great partnership with all of them. We are starting one with Mason as well here shortly too. So that's been good collaboration for sure.
And the change with 5536 that we'll talk about a little bit too, and personal possession becoming a gross misdemeanor. There will be a lot of meetings, already having some meetings around implementation of that and how that's going to play out. My hope is that will result in a lot more referrals from law enforcement, and anyone eligible that's now being contacted under that charge would be referred to LEAD or a similar program for services. So the dashboards, we've started creating these using some of the data that we collect in the electronic health record system. So this highlights a lot of kind of the main aspects of the program in terms of how many people we're serving, how they're being served, the general demographics, and highlighting some of the supports that they're receiving through the program. So like I already mentioned, there's, in the bottom middle, there's a lot of people that are they're unhoused interacting with the program. You can see on the bottom right that highlights some of the linkages to care. Linkages to care is not just a referral. Linkages to care is an actual connection is made, whether that's the peer case manager driving the person to their appointment or filling out the paperwork and checking in with them afterwards to make sure they got there. We don't do any cold handoffs or here's a phone number, call them and make an appointment. The team is very proactive in making sure that people get their needs met. And we've seen huge impacts and successes in that regard with things as simple as going to the local CSO to apply for benefits. The ability to have a peer show up with them that's able to speak on their behalf has really changed some of the outcomes and experiences that people have when trying to access resources in our community.
CSO, can you?
Yes,
Just put
sir.
it forward.
Going to the DSHS to apply for benefits. So whether that's HEN, trying to get on with Medicaid, some of the food resources, yeah.
I'll add that there are a lack of treatment facilities locally, so a lot of the transportation are to places like Vancouver or Pierce County or King County. So we do get folks to wherever they need to go.
Yeah. Yeah, and that's another thing to highlight here. Even though this program is at its core harm reduction, is very, very true and similar to what we've seen in other surveys of this population. They want help. They are interested in help. A lot of people, once some trust is developed and they start working with a case manager, do say, can you help me get to withdrawal management? Can you help me get to treatment? I do want to start mental health meds. So there's huge benefits in meeting people where they're at, on their level, advocating for their needs on behalf of them. That leads to greater change, or maybe would more traditionally be seen as progress towards recovery. But it's, yeah. So we're doing this on a quarterly basis now to provide updates around what's happening with the program. This first one captures calendar year 22 incomplete numbers. The linkages to care are a little bit underreported here because some of those measures weren't captured for the full year. And then this is the first quarter of this year, some of the numbers. So far, pretty on trend with what we were seeing last year. Linkages to care, I think, is going to be a lot higher for this year. And we'll see how the impacts of 5536 affect things like referral sources.
On your veterans housing and PPW, their status graph.
Yes.
Would most of those veterans fit in that unhoused category as well? Or?
Yes.
So
yeah.
I guess I'm just wondering, well, okay.
We've had a combination of some unhoused, some housed. We had some veterans referred from Drexel House that have engaged with the program. And we're lucky that we have a really diverse team of case managers with relevant lived experience. A couple of those case managers happen to be veterans themselves. So they're connected to the VA system. We work with the Veterans Hub in Lacey quite a bit. Ensure that we really connect whoever we get to all the appropriate resources to support them. Whether that's accessing general benefits and or housing options, because I know there's some additional housing options for veterans in our community. And PPW should really be clarified as pregnant parenting women. So relatively smaller category, but still a priority population for a lot of our funding at the ASO.
Do you keep track after you've had interaction with these folks and now you know who you're helping? Do you keep track of where these folks are from?
In terms of, like as far as, did they come to this community from outside?
Yep, from where, those that are from Kansas City,
Right.
which is anything but here, versus the South Puget Sound. And the only reason I ask that question is because I hear this from law enforcement all the time and from the medical folks. When they finally get the interaction and they have to find out where they're from because of a violent situation or a medical situation, they find out about 60% of them or more are from elsewhere. But when we do the point in time, it says 16% are from elsewhere.
Right.
So I'm trying to figure out what's correct. And you guys undoubtedly are in a situation where you can know where these folks are from. And our problem for me is on the whole homeless thing, that we can't take care of the whole darn country. I think we have access and resources to take care of those that are from our own communities that have fallen on hard times, and at least prioritize service to those folks first to kind of discourage folks from coming from Kansas City. So I don't know if you've got that metrics anywhere in there, but if you don't, I think you ought to have it. Not necessarily so you can discriminate against one or the other, but at least know it. So from the public policy perspective, we'll be able to ask that question and get an answer. Right now, we get speculation. We don't get facts. And that happens on a lot of things, not just your operation.
Yeah, we don't have that exact metrics captured in the health records.
It's not a health record. I'm not asking for any health records.
That's where we capture a lot of that stuff.
Where are they from?
Right.
It's a pretty simple equation. I can't get the point in time people to ask for verification on that. Because it's HUD or whatever. I don't know the funding, I suppose, but.
Well, and a lot of what we collect is self-reported. So there's always going to be some gaps in data when it's based on self-report. So somebody might talk about where they were from for the last 5 years.
Well, eventually though, when you start handing out money, getting them signed up on programs, getting them housing, I'm hoping you find out a little bit about them.
Definitely.
You know, make sure they're not the Jack the Ripper from Kansas City.
Yeah. Well, in the weekly groups I talked about, the operational work groups, we will screen people for any risks or outstanding legal issues, things like that, to try to help identify, are there safety concerns for the case management team? Are there safety concerns for the other community? What housing options might not be available? Anecdotally, I know that we've only had, that I can think of, 2 or 3 people that we knew from out of the area, and we only know for sure they were from out of the area because we helped them get back to where they were from. One of those people was unhoused in Lacey for a long time and was well known to Lacey PD, and had a lot of interactions for a few years. And through some of the shifts that were supported by the MOT team, LEAD, and Lacey's community outreach as well, that person became more open to working with the police and started to see them less as an enemy and have less adversarial interactions, and led to getting help to go home and reunite with family.
That is hard for people to do when there's a warrant outstanding for them from their home jurisdiction.
Right. Yeah, that's a factor. Yeah. Any other questions about who we're seeing? Okay. Another aspect of the contract that I'm excited we're in compliance with is participant surveys. So beyond being required to, it's a best practice to engage the population you're serving with how they think they're being served. A little difficult to read, I think, on the screen, but there's several questions that we asked that they rate on a 1 to 5 scale, 5 being the best. And then there's a few open-ended questions that they respond to as well. Overall, people are responding really positively to the program and appreciating the services that they're getting. They feel like there's someone on their side. They feel like they know where they can go for help. The lowest rated response we get is, do you feel safe? For that specific question, we've had at least 3 people write in on the survey. That's why I continue to engage with the program. So it's not feeling safe is not a direct reflection on the program as much as it's or a negative one, I should say, it's a positive reflection in that they continue to utilize services to feel more safe in their life circumstances.
And 4.9 is out of 5? 10?
Yes, yeah. And so we do these at 6 months and then again at a year of engagement with the program to kind of have a rough baseline and see how we're doing overall. We try to collect them anonymously so they don't feel like their case manager is looking over their shoulder as they respond to these. And this has already kind of got into successes because of the positive responses we're getting, but on this next slide is a few quotes from participants in the program, and it's hard to capture how much success there's been through this program. I get to hear about it most days, and definitely on a weekly basis at those operational work group meetings, updates around a lot of people that have been able to access housing that's been facilitated and supported by the team. People are becoming employed thanks to engagement with this program. We have people enrolling at South Puget Sound Community College, people completing their certified peer counselor training to do the work themselves, helping other people. People are getting legal issues resolved. We don't get a lot of families, but we've had a few families referred to the program, and the team has facilitated, getting children re-enrolled in school, helping those families transition from living in a car to living in an apartment. Undeniably powerful, life-changing work is being facilitated by this team. For a lot of these people, it would not happen any other way. A lot of them are unhoused and experiencing the difficulties they are because the traditional resources and options don't work for them, or it's too high barrier for them to access. And this team is able to engage them out where they are in a way that's meaningful to them and walk alongside as they progress in their life and start to put things together in a way that works for them and makes sense for them.
Can I ask
Yes.
a question? First of all, I know John's gonna like that last comment there, but going back, is there any connection with the resource hub through all of this?
Yeah, we've had referrals both ways, both from the resource hub to LEAD, and also LEAD is taking people to the resource hub to connect with other providers that are there as well.
Okay. Just trying to see like that interconnectivity, and I know this is something new that we've started to do, so just wondering how that's working out, and so it's good to hear that there's referrals both ways.
Yeah, and the team has been really proactive in just generally trying to make sure they're well connected to the community. They've invited other program agencies in to talk about their programs and do information sharing. They've really embraced this. We are a community. We're a community of providers. How can we best serve each other and help each other out? And the resource hub has been a great connection point for a lot of providers. That I know of, there's at least 5 to 10 that are there on a really regular basis. So being able to access that has been helpful. Again, there's a quote up there, yes, about hope. One of the things that I've seen be really inspiring out of this is for a lot of people, being able to have someone show up and be there for them and do that in a non-judgmental way that provides them with dignity and respect helps put someone in a position where they can even begin to have hope. A lot of the people that we serve have been failed by multiple systems multiple times. And it takes real work and dedication on the part of the case managers to build someone to a point where they can even begin to have hope. We're really lucky with who we have doing this work. It's inspiring. And like the quote up there says, like very literally, this program has saved my life. We hear that a lot, and it's not figurative, it's literal. People have been revived with Narcan by the team. They're doing training and overdose prevention work out in the community. Like I said, with the healthcare, we've had unhoused people fall and break their hips that have then been supported in accessing the hospital and finding respite care and then transition to housing. I don't know if you've tried to recover from a broken hip unhoused, but I can't imagine that would be very feasible. And really basic things, just like human connection. There's a recent Surgeon General's report on that about how impactful isolation and loneliness are on overall health. And the team has done really inspiring things like invite some of the participants to hang out to the office and have like a group kind of arts and crafts time and ability to just socialize and get some connection that they aren't experiencing anywhere else. So
Can we talk about the housing aspect for a
Yeah.
second? Because housing is, I mean, that's an issue that we're really struggling with. There's just not any. And so when you're working with these folks to try to get them housing, and do they go to the top of the list for the coordinated entry? How does that work?
I wish we could get a front door, first of the line access. So it's completing the coordinated entry intake, getting them onto the list to start. Depending upon what kind of other issues they have going on, they might be able to do what's called a bypass. Usually that's related to other high-risk conditions like medical conditions, behavioral health conditions, other risk factors that make it more dangerous for them to remain unhoused. For those people, they are able to kind of bump towards the front of the list for placement. We work with a lot of the local shelters to try to brainstorm options for people. A lot of times, though, it's continuing to provide support with where they're at, which often is somewhere unhoused. So whatever we can do to help keep them stable and engaged while we work a list of the different options, while we help look for other funding streams for them. For any of the individuals that go the traditional treatment route, there are a lot of recovery house options and recovery housing support options. So they might engage with Northwest Resources housing case managers. They're going to get them placed in like an Oxford house.
Or through our own
Right.
housing and referral through peer services, and also makes them eligible for what's called CBER funding, which is community-based rental assistance for individuals coming out of inpatient services. So we are able to, and that's outside of coordinated entry, so we can help them that way too.
Yeah. And we have an undeniable lack of housing options and resources in our community.
Hey, Jason, go back to the testimony. Last summer, I believe you organized a celebration. And I think it was very impactful to see the faces of those individuals involved in the system. I attended, that was very touching. Are you planning to have similar event this summer as a celebration?
I think we just decided to.
Because really, it was all the members involved. I mean, it was law enforcement, elected officials, everybody involved. And it was a celebration just to have this firsthand testimony, putting a face to those individuals impacted. It was powerful. And I believe the commissioners will certainly appreciate that opportunity.
Yeah, thanks for mentioning that. Yeah, that was fun and it was impactful. It was moving.
And it was important. The folks that we have doing this work are certified peers. They're folks with lived experience, and we have drug court graduates that are, employed with us now and doing this work. And it was meaningful for them also to have law enforcement and elected officials there supporting the work that they're doing. So that works both ways for sure.
Definitely. Yeah. We're approaching the end here. Real quick. So Romero mentioned towards the beginning some lessons learned and kind of what's next. So wanted to make sure we include this. Throughout administering this program, we've learned a lot about just how to train our referral sources effectively, how to help ensure that we're having the right people referred to the program that are most impacted and going to benefit the most from the services that are offered. So ensuring that it's very clear that this is not a crisis program. We don't do crisis response. This is a long-term, ongoing case management program. That doesn't mean that a lot of our people aren't in and out of crisis, because many of them are. But this is more about stabilizing and help someone move from living in a cycle of crisis to more goal-oriented, stable living. We've tried to be really flexible with our referral process. The one example that I think is really cool is the Tumwater Fire Department adapted their health record to include our referral form into their health record, so that could just be automatically forwarded whenever they contact anybody. And those are primarily when they're responding to overdoses that they have sent people our way. We've also just generally tried to be really flexible with, we'll take any information you've got and you're willing to give us and tell us where someone's at, and we'll go try to find them and engage them in services. Along those lines, getting where someone is, as well as a detailed description, is always helpful. It's hard to find somebody to just walk down the street yelling at random name. So where someone is and what they look like definitely has turned out to be an important thing to include. And then just developing some really solid outreach procedures around when we get a referral, we'll respond by this time. If we don't contact anyone within this first week, we're going to contact the referral source, let them know we had trouble finding your person, you know where they might be. Just some standardized process around how we do that and ensure that there's a good communication feedback loop for the people that are referring to the program. Some of the big things that are coming up that are going to impact the program is going to be that 5536 implementation, with personal possession becoming a gross misdemeanor now, and encourage diversions both at the law enforcement level as well as the pretrial level. And like I already said, I hope and believe that LEAD will be a really key component in responding to that effectively and providing resources for people. And then, leveraging the community advisory board that we have, as well as other groups that meet to talk about how to best implement 5536 locally and how to best respond to the people that are being contacted by law enforcement that could benefit from services. And a little bit about what's next so far. Happy to answer any other questions from the commissioners.
Can you stop sharing?
How many people do you think you've helped? Any idea? Because it's gonna be
You
different
have
levels.
numbers.
Yes, I do. Yeah, well over 200 at this point.
But at the same time, when you're helping somebody through this problem, you're also alleviating jail overcrowding and different
Definitely.
workload issues with the prosecutor, public defense and stuff. So, I mean, a lot of times I get asked, well, is it worth it? Well, what's somebody's life worth, so how do you equate that? But it's, if you could have those kind of numbers, you can't measure the positive, you can't measure they didn't kill somebody, or, that kind of thing, but just a little bit of a comparison, I think would help, just, we're solving the community's problems.
Definitely. I mean, I think it's safe to say that everyone that's been in this program has benefited from developing a sense of connection and trust and assistance with accessing resources, to the more extreme, like I mentioned, where it's people are enrolled in school full-time, people are working full-time, people are housed, people are contributing members of society. People are doing the work themselves to help other people along. Definitely huge impacts around system costs, less emergency room utilization, less law enforcement response, all of that.
Do you help with job, location of jobs and stuff?
Yeah. I think it was last week's meeting or the one before, the team was talking about helping participants work on resumes and cover letters. And we've done other things with some of the flexible funding, like buy people work boots, make sure people have what they need to do the job they're trying to do. Help them with, how to navigate getting enrolled in school and what benefits are available to them. So.
There's a really important point in this last couple of comments, and that is that the LEAD program, I think, there's been concerns raised about, well, your arrest diversions are down, like we were talking about earlier, right? You're not diverting as many people from arrest, and there's reasons for that. But the social referrals from all these other sources are way up, right? People are coming in through other doorways, but they're still getting to the program. And all of these folks, as was indicated, there's engagement in the legal system, right? So at the end of the day, LEAD has shifted from as much of arrest diversion to arrest prevention. I think that's a really important point, because to me, that's even better, right? I'm all for diversion. I think down the road, we're gonna get back to arrest diversion, particularly when 5536 comes on board. And you'll see those numbers go up. But as far as I'm concerned, arrest prevention, that's goal achievement for me right there.
We have one concrete number I could think of a definite 911 system improvement where we had a referral that was calling 911 probably at least 100 times a week, if not more.
How many times?
100 times a week. And isn't anymore. They're calling the lead team
100 times a week.
sometimes, but either way, I mean, there's that shift of they're getting a more effective response that can more adequately meet their need. So.
Great. Well, we've reached our time. It is 11:01. Thank you all for coming. With that, we are adjourned.